Welcome to the deep dive. We take complex topics, break them down, and pull out the essentials you really need. Today, we're zeroing in on the syndrome of inappropriate antidiuretic hormone, SIADH. If you're prepping for the MSRA or really any medical exam, this one's absolutely key.
It really is. And our mission today, if you like, is to give you that high-yield overview, everything you need for revision on SIADH.
Right.
We'll cover, the definition, what causes it, who is at risk, how it works.
What else it might be.
Exactly. Differentials, who gets it, how it actually looks in a patient, diagnosis, treatment.
Prognosis, complications.
Yeah.
The whole picture.
It's full picture. We know this stuff can get dense, so we'll try and keep it super clear, maybe throw in a memory aid or two.
Perfect. Okay, let's dive straight in then. What is SIADH, basically?
Okay, so fundamentally, SIADH means you've got too much antidiuretic hormone ADH floating around.
The water-retaining hormone.
That's the one.
Yeah.
So when there's too much of it, your kidneys get the signal to hold on to water, like way too much water. And all that extra water dilutes the sodium in your blood. So you end up with low sodium hyponatraemia.
Even though the person isn't actually, dehydrated, their overall fluid might seem okay.
Precisely. That's the weird bit. The classic triad you're looking for is 1, low blood sodium, 2, really concentrated urine, high urine osmolality.
Meaning packed with stuff, not watery.
Exactly. And 3, what we call euvolaemia. They look like they have a normal amount of fluid overall, no obvious dehydration or overload, usually. And this happens either because something's making the body release way too much ADH, or sometimes the kidneys themselves just become overly sensitive to even normal ADH levels.
Right.
But, and this is crucial, you absolutely have to rule out other things that cause low sodium before you can diagnose SIADH.
Yeah, good point. It's not the only game in town for low sodium.
Yeah.
So what does cause this ADH overload or supersensitive kidney thing? The etiology.
Okay, causes. We can sort of lump them into a few buckets. First, tumors. Think cancer. Especially, and this is a big one for exams, small cell lung cancer.
Okay. The classic link.
Definitely. Then you've got central nervous system disorders. That's pretty broad: infections, strokes, head injuries, things like that.
Right, brain stuff.
Brain stuff. Then pulmonary diseases, so lung conditions, pneumonia, TB, even things like asthma sometimes.
Lungs, too, okay.
And finally, medications. Some common ones, actually. Certain antidepressants like SSRIs, some anti-epilepsy drugs. Carbamazepine is a classic.
So drugs can do it, too.
Absolutely. So maybe a way to remember the big categories: TCP mnemonic, tumors, CNS, pulmonary, meds.
TCPM, I like it. Tumours, CNS, pulmonary, meds. Got it. So, knowing the causes, who's more likely to get this? Are there specific risk factors?
Yeah, there are. And they overlap a lot with the causes, as you'd expect. Advanced age is definitely one. Older people seem more prone to it.
Okay.
Having a malignancy, especially that small cell lung cancer we mentioned, is a major risk factor.
Right, makes sense.
Various pulmonary diseases increase the risk. Same for CNS disorders. And of course, taking one of those culprit medications puts you at higher risk.
So it lines up pretty closely with the causes themselves.
It really does.
Okay, so we've got the what and the who. Let's dig into the how, the pathophysiology, what's actually happening mechanistically.
So the core problem is just too much ADH activity. Either too much is released or the kidneys respond too strongly.
Okay.
This ADH tells the kidneys, specifically the collecting ducts in the kidneys, to put in more water channels, aquaporins.
Right.
So the kidneys reabsorb more water back into the bloodstream than they should. Free water, mostly.
And that extra water dilutes everything.
Exactly. It dilutes the sodium in your blood. So serum sodium drops hyponatremia. And remember, the ADH might be coming from the usual place, the pituitary, just too much of it, or it could be ectopic.
Meaning coming from somewhere else.
Yeah, like a tumor making its own ADH. Or it could be normal ADH levels, but the kidney is just overreacting.
Gotcha. Kidneys holding water, sodium gets diluted. But, as we said, low sodium doesn't automatically mean SIADH. What else do we need to think about? The differential diagnosis.
Crucial, this bit. Especially for exams. You've got to consider things that mimic it. So think hypothyroidism.
Underactive thyroid.
Yep. It can sometimes cause low sodium, so you absolutely need to check thyroid function tests, TSH, free T4.
Okay. H, what else?
Adrenal insufficiency. Addison's disease, for example. Problems with the adrenal glands not making enough cortisol can also mess with sodium and water balance.
Right, so check cortisol levels.
Definitely. A morning cortisol, maybe an ACTH stimulation test if you're suspicious. That's A.
HA?
Then renal dysfunction itself. Are the kidneys just failing? You need to look at their overall function creatinine, eGFR. Kidney disease can cause all sorts of electrolyte problems.
Makes sense.
And finally, diuretics. Probably one of the most common causes of low sodium you'll see, especially thiazide diuretics.
Water pills.
Exactly. So you must take a really careful medication history. Are they on any diuretics? So that's D.
HARD?
Yeah.
Hypothyroidism, adrenal insufficiency, renal dysfunction, diuretics.
Hard to rule out.
Yeah.
Exactly. It's a good checklist.
Nice one. Okay, hard. Now, how often do we actually see SIADH? Is it common? The epidemiology.
It's definitely seen most often in hospitalized patients. It's not something you typically diagnose walking around in the community, although chronic cases exist. And it's particularly common in patients who have cancer.
Write that link again.
Yeah. So hospital setting, especially with malignancy, that's where your index of suspicion should be highest.
Okay, so let's imagine a patient who might have it. How would they actually present? What are the clinical features we'd see?
Well, it really depends on how low the sodium is and how fast it dropped.
Okay.
Initially, especially if it's mild or chronic, the symptoms can be really vague, like nausea, maybe some vomiting, headache, just feeling generally unwell or fatigued.
Non-specific stuff.
Very nonspecific. You might see some weight gain, but often without obvious swelling because the extra fluid is more inside the cells initially.
Right.
But as the sodium gets lower, or if it drops quickly, you start seeing more serious neurological signs. That's because the low sodium affects brain function.
Like what?
Confusion is a big one. Lethargy, drowsiness. It can progress to muscle cramps, weakness, and then really serious stuff like seizures or even coma.
Wow. Okay, so it's a spectrum.
Definitely a spectrum. And clinically, you're trying to piece together these symptoms with that diagnostic triad we mentioned: low serum sodium, urine that's inappropriately concentrated for that low serum sodium, and the patient looking euvolemic after you've done your hard check for other causes.
Got it. So vague symptoms up to serious neuro problems plus the lab findings.
Precisely. Always ask about mental status changes, any seizures, nausea, vomiting.
Right. So we suspect it based on all that. What tests confirm it? What investigations do we order?
Okay, investigations. First off, you need the basics. Serum electrolytes, sodium, potassium, also serum urea and creatinine to check kidney function, and serum osmolality, how concentrated the blood is.
Blood tests first.
Yeah. Then, crucially, you need urine tests at the same time: urine osmolality and urine sodium concentration.
Okay, why those?
Well, in SIADH, you expect the serum sodium to be low and the serum osmolality also low because it's diluted. But the urine osmolality will be inappropriately high, usually over 100 osmolality, often even higher than the serum osmolality. The kidneys are concentrating urine when they shouldn't be.
Right. Holding on to water makes concentrated pee.
Exactly. And the urine sodium is usually elevated too, often over 40 millimole, assuming they're eating a normal amount of salt. That helps differentiate it from dehydration, where the kidneys would be desperately trying to hold on to sodium.
Got it. Low blood sodium osmo, high urine osmosodium.
That's the pattern. Then, of course, you need tests to find the cause. Imaging, like a chest x-ray or CT scan, looking for lung cancer or other lung issues, or brain imaging if you suspect a CNS cause.
Hunting the trigger.
And don't forget those hard differential tests: serum cortisol for adrenal function and thyroid function tests for hypothyroidism. You need to rule those out formally.
Right. Bloods, urines, hunt the cause, rule out hard. Okay, makes sense. So let's say we've diagnosed it. How do we manage SIADH? What's the treatment plan?
Management has two main goals. One, safely correct the low sodium. Two, treat the underlying cause, if you can find one and it's treatable.
Okay. Safety first with the sodium.
Absolutely. You don't want to correct it too fast, especially if it's been low for a while, because that can cause osmotic demyelination syndrome, serious brain damage.
Right. Slow and steady.
Slow and steady. The main non-drug approach, especially for mild or moderate chronic cases, is fluid restriction.
Just drink less.
Pretty much. Often limiting intake to maybe 800 milliliter or 1 liter per day. This helps the body catch up and get rid of the excess water.
Okay.
If it's more severe or the patient is very symptomatic, like having seizures, then you might need to use intravenous hypertonic saline. That's basically concentrated salt water.
To push the sodium up faster.
Yes, but it has to be done really carefully, usually in an intensive care setting with frequent sodium checks.
High alert stuff.
Definitely. Sometimes diuretics like furosemide can be used, often along with salt tablets, to help get rid of the excess free water.
Right.
And critically, if you identify a cause, stop the offending drug, treat the infection, manage the underlying cancer if possible, that's key to long-term control.
Address the root problem.
Always. For some chronic cases where fluid restriction isn't enough or not tolerated, there are specific drugs called vasopressin receptor antagonists, like tolvaptan. They directly block ADH's effect on the kidney.
Ah, okay. Specific blockers.
Yeah, but they have their own monitoring requirements, too.
So fluid restriction, first line, maybe saline or diuretics for severe cases, treat the cause, and maybe specific blockers later. What about the non-drug side, apart from fluid restriction?
Patient education is massive. They really need to understand why they're restricting fluids, what symptoms to look out for if their sodium drops again, and when they need to get help.
Yeah, adherence must be tough.
It can be really challenging, especially long-term, so good education and support are vital.
Okay, and looking ahead, what's the prognosis? What can patients expect?
It really hinges on the underlying cause. If you've got SIADH because of a medication you can stop or an infection you can clear, the prognosis is generally excellent. The SIADH often resolves completely.
Good news there.
But if the cause is something chronic or progressive, like metastatic cancer, then managing the SIADH becomes part of managing that condition, and the prognosis is more tied to the cancer itself.
Right, depends on the trigger.
Yeah. And the severity matters, too. Mild, slowly developing hyponatremia usually has a good outcome with treatment. Severe, rapid hyponatremia is more dangerous and carries a higher risk of complications, even with treatment.
Okay. So speaking of complications, what are the mixed risks we need to watch out for?
The biggest dangers relate to that severe hyponatremia. Neurological problems are top of the list. Seizures, coma, potentially irreversible brain damage if it's very severe or prolonged.
Scary stuff.
Yeah. Also, the rapid correction of chronic hyponatremia, as I mentioned, can cause osmotic demyelination syndrome, which is also devastating.
Right, the correction itself is risky.
It has to be managed carefully. Other potential issues, though less common, could be things like cardiac arrhythmias, especially if other electrolyte imbalances are present. And although euvolaemia is typical in some severe cases, you might get enough fluid retention to cause pulmonary edema fluid in the lungs.
Okay, so mainly neuro risks from the low sodium or its rapid correction.
That's the main thing to be vigilant about.
All right, so quick recap for everyone revising. SIADH, too much ADH action, leads to low sodium, hyponatremia, concentrated urine, but usually normal fluid volume, euvolaemia.
Spot on.
Causes. Think TCPM, tumors, small cell lung, CNS, pulmonary meds, differentials, remember heart, hypothyroidism, adrenal insufficiency, renal dysfunction, diuretics. Rule them out.
Crucial step.
Investigations. Serum and urine sodium and osmolality are key. Then hunt the cause with imaging, cortisol, thyroid tests, management. Correct sodium safely. Treat the underlying cause. Fluid restriction is often first line. Maybe hypertonic saline diuretics or ADH blockers in specific cases.
Good summary.
Prognosis depends heavily on the cause. Complications are mainly neurological due to severe low sodium or rapid correction.
You've nailed it. And maybe just to add, for your MSRA prep, think about those clinical vignettes. An older smoker with confusion and low sodium? Think SIADH. Someone started on an SSRI, now feeling nauseous with hyponatremia. Think SIADH.
Great exam tip. Always link it back to the likely causes.
Exactly. Look for those clues.
Fantastic. Well, for loads more high-yield revision resources on SIADH and everything else you need for the MSRA, definitely head over to passthemsra.com.
And check out freemsra.com as well for free questions and guides.
Brilliant resources. Thank you so much for breaking down SIADH with us today.
My pleasure. Hope it was helpful for everyone listening.
Absolutely. Thanks for joining us on the deep dive. We'll catch you on the next one.